Okay, Bismillah ar-Rahman ar-Rahim, guys. Assalamu alaikum wa rahmatullahi wa barakatuh. We're going just to continue our previous session of neuroinfections for MRCP. We stopped in the previous session at herpes simplex virus encephalitis, and we are going to continue today, and we start with cytomegalovirus encephalitis. Of course, in a scenario of cytomegalovirus encephalitis, when you suspect this diagnosis, if you have been given either a patient with HIV, maybe directly or indirectly a patient is a homosexual or drug abuser, or already have been diagnosed with HIV. In these patients, you will be given the CD4 count, and it will be very low in these patients. So usually it's below 50. And the patient is presenting with symptoms and signs of encephalitis, as we discussed before. So it's just in short, so confusion and memory changes and depressed conscious level. We may have also some focal neurological deficits. We usually have seizures and fevers. So these constellation of symptoms indicate the presence of encephalitis. If in the context of HIV patient with a very low CD4, below 50, you have to suspect also cytomegalovirus encephalitis. Also, if you have evidence of visual problems, because there is usually associated cytomegalovirus retinitis, where there may be some scotomas, some flashing or flutters, and also even up to complete loss of vision on one side or both sides. And of course, the fundus examination will show these areas of retinal hemorrhage and these white spots. It's a characteristic feature of cytomegalovirus encephalitis. In some scenarios, it may be not HIV. It may be just the patient is receiving some immunosuppressive drugs like tacrolimus, like cyclosporin, after organ transplantation, like renal transplantation. So you have to suspect cytomegalovirus encephalitis in the presence of symptoms and signs of encephalitis and HIV with a very low CD4 count, or a patient with a post-organ transplant receiving immunosuppressive drugs. The MRI is non-specific, and diagnosis mainly is based on the clinical picture, and also very low CD4 count and the presence of the retinal changes on fundoscopy. Usually there is a high HIV viral load and a positive cytomegalovirus PCR. Okay. Regarding the treatment, you may be asked also about the treatment of such patients. So you need to diagnose first. To if the treatment is mainly ganciclovir, or if there is resistance to ganciclovir, the other option will be foscarn. So foscarn is used in resistant cases to ganciclovir. In case of associated retinitis, it may be used intravitreous, so intravitreous ganciclovir or intravitreous foscarn. Also, cidofovir may be used. In secondary prophylaxis after the acute attack, valganciclovir could be used. So, for the treatment, initial treatment is ganciclovir. If resistant, use foscarnet, and for secondary prophylaxis is valganciclovir. This is an MRI finding, and as I said, it is a non-specific, actually. Okay. Limbic encephalitis, if you remember when we spoke about meningitis, we spoke about carcinomatous meningitis in the patient in the context of cancer, like lung cancer, breast cancer, or lymphoma, and its subacute manifestations of meningitis and absence of evidence of infection, and it was a kind of lymphocytic CSF. Here also it's quite similar, but in the presence of encephalitis. So reduced conscious level, confusion, seizures, and it's also subacute. And because it's named limbic encephalitis, it sometimes it's considered as a paramalignant syndrome because it can occur in the context of small cell lung cancer. Or it may be autoimmune in the absence of apparent cancer. Like carcinomatous meningitis, it's also subacute because it's limbic encephalitis affecting the limbic regions, affecting the hippocampus, affecting the amygdala, and so the main presentation is a subacute presentation of memory changes, so short-term memory loss, and behavioral changes, and associated with confusion and seizures. So subacute behavioral changes and memory changes in the context of lung symptoms indicating maybe small cell lung cancer, you have to think in this possibility. Of course, the MRI, usually there is affection of the temporal lobe. So temporal lobe usually is affected in herpes simplex virus, cytomegalovirus, and in limbic encephalitis, the limbic plus limbic, it changes. The CSF is sterile CSF, like the case in carcinomatous meningitis, if you remember. Sometimes there may be a clue in the scenario, like the presence of hyponatremia due to the presence of antibodies against voltage-gated potassium channels. The treatment, because it's kind of autoimmune, it mainly relies on IV immunoglobulins and plasmapheresis, and steroids can be used. So the treatment is similar to that of autoimmune conditions like Guillain-Barré syndrome, for example. So this is one of the pictures. It's non-specific, as I said. So both temporal lobes here are affected bilaterally. So limbic encephalitis, it's equivalent of carcinomatous meningitis, and mainly in the context of small cell lung cancer, or maybe autoimmune in the absence of cancer. HIV-related infections or HIV-related problems, many infections can arise, but the common scenarios which appear in the exam in MRCP Part 1 or MRCP Part 2, the first is the dementia. So the patient coming with memory loss, patient coming with confusions, and all manifestations of dementia. No focal neurological signs at all in these patients, no seizures at all, so just memory changes and reduced cognitive functions. In the context of HIV patients, it's related to HIV directly, so it's called HIV-related dementia, and its main treatment is antiretroviral therapy. Okay. The other thing is the progressive multifocal leukoencephalopathy, and this is a high topic in the exam also. It can arise in the form of also memory changes, and it also can moody changes sometimes, focal neurological deficits, seizures. So the difference between progressive multifocal leukoencephalopathy and HIV-related dementia is the presence of focal neurological signs. It's a white matter affection in the periventricular region. So how to differentiate? We have memory changes, we have cognitive impairment, and focal neurological signs. So you may have some sensory deficits, you may have seizures, you may have a motor weakness, upper motor neuron weakness. And so that's the main thing that differentiates progressive multifocal leukoencephalopathy from HIV-related dementia, and it's related to what's called JC virus. And its main treatment also is antiretroviral therapy. Back to this slide. Third thing, cytomegalovirus encephalitis, we already discussed, and toxoplasmosis, also one of the high-yield topics in HIV patients. So usually the scenario is the patient with HIV or maybe just mentioning that the patient is a drug abuser or homosexual and has other symptoms related to HIV, or directly you may be given in the scenario that the patient already diagnosed with HIV and he has a low CD4 count and presenting with some focal neurological signs or confusions or seizures usually, and usually you will be given in the scenario the CT finding of the patient and or the MRI finding of the patient also, and usually the CT finding it shows multiple ring enhancing lesions. So once you see this multiple ring enhancing lesions in a patient with HIV and presenting with such symptoms like seizures or confusion or focal neurological deficit, it is toxoplasmosis. Sometimes it's a single ring enhancing lesion, or sometimes it's multiple ring enhancing lesions. And the main treatment in these patients, in the case of presence of cerebral edema, steroids are given in addition to sulfadiazine, pyrimethamine, and folinic acid. So you suspect toxoplasmosis in a patient with HIV and presence of single or multiple ring enhancing lesion on CT. Okay, get back to this slide. Cryptococcal meningitis, we already discussed. Sometimes HIV patients present with a Guillain-Barré-like syndrome. So typical picture of Guillain-Barré-like syndrome, and in HIV patients. So a patient presenting with paresthesias and ascending weakness affecting lower limbs and affecting the upper limbs, and associated with some sensory deficits or loss of reflexes and complete paralysis. Also respiratory muscles may be affected. So picture typical like a Guillain-Barré-like syndrome. In the context of HIV patient, usually the diagnosis is HIV related Guillain-Barré-like syndrome. So you may be given this scenario and you may be given possible diagnosis, and in the context suggestive of HIV or the patient already diagnosed with HIV, the main diagnosis will be HIV related neuropathy. So it's not a typical Guillain-Barré syndrome. Okay. One of the important infections also in neurology, also the Ramsay-Hunt syndrome. This is a form of herpes zoster infection, and it can present with unilateral facial palsy. It's related to reactivation of the herpes zoster virus in the geniculate ganglion, and lead to unilateral facial palsy plus like shingles. So it's like vesicular rash appearing in the ear, sometimes appear in the uvula or on the neck. So unilateral facial palsy plus vesicular eruptions in the external ear or in the neck or sometimes in the uvula. And this is usually this is the spot diagnosis, classic diagnosis, and the treatment is mainly by steroids plus acyclovir. So usually this diagnosis is straightforward in the scenario, and the main treatment is acyclovir plus steroids. Okay. Also, Lyme disease. Lyme disease is also one of the high yield scenarios, high yield topics in MRCP Part 1 and MRCP Part 2, and usually you have to suspect this if the scenario speaks about the patient presenting with some neurological manifestations after a history of camping, and there may be usually the history of tick bite or the history of skin rash, that is the erythema migrans, and neurologically the patient may present with meningoencephalitis and one of the common and one of the typical scenarios, the bilateral facial palsy. So bilateral lower motor neuron facial pulses one of the typical scenarios of Lyme disease in MRSP exams. So if you have a history of rash and facial palsy, that's Lyme disease. And the main treatment of these cases, even before the results of lab, so you have to start the treatment immediately once clinically diagnosed. And it's mainly, the treatment is ceftriaxone or deoxycycline. Viral hepatitis can indirectly affect also the nerves, and we will cover this. A hepatitis B virus can lead to, it's maybe associated with the polyarthritis nodosa and vasculitis, and it can affect the vasovasorum of the nerves and lead to mononeuritis multiplex. Hepatitis C virus is commonly associated with a cryoglobulinemia and also leads to a form of neuropathy and mononeuritis. So hepatitis C virus can lead to mononeuritis through cryoglobulinemia and a form of hypercoagulable state, and also hepatitis B virus can lead to vasculitis and may be associated with a polyarthritis nodosa. In the drug abusers, usually there are two important scenarios in drug abusers. The first one is the botulism, and these patients usually, these scenarios in the exam represent in a patient with a drug abuser, maybe single or multiple wounds, and the patient present with a descending flaccid paralysis, so starting to affect the eye and the bulbar symptoms. So it may be bilateral ptosis and also dilated pupil, and at the same time we may have also ophthalmoplegia and dysphagia, dysarthria, and then affecting the upper limbs and lower limbs, and can affect only the respiratory muscles and intercostal muscles. So they need support to treatment in the ICU because ventilation may be needed in these patients. This is usually a classic scenario. You have to suspect in a patient with IV drug abuser presenting with ophthalmoplegia and bilateral ptosis and descending paralysis. The main treatment of these cases is the antitoxin. This botulism is related to a pre-formed neurotoxin produced by Clostridium botulinum. So the main treatment is to supportive treatment in the ICU, and you may be asked about the antibiotic treatment, so giving some coverage for the anaerobes, and the main treatment will be also the anti-botulinum toxin, so antitoxin. Tetanus, it is the other part of this drug abuser related infections, and it's associated with spastic, spastic paralysis, and usually this is a clinical diagnosis. Spot diagnosis also can occur in drug abusers or in deep wounds, and the patient presented with trismus, dysphagia, and spasms, and a clear form of spastic paralysis. And the main treatment of these cases also supportive treatment, and also IV immunoglobulins, anti-tetanus immunoglobulins, and also some supportive treatment like muscle relaxant or diazepam or lorazepam. So the main treatment for the Clostridium tetani in these patients, because this is anaerobic spore, it's covered by the antibiotics, mainly metronidazole. This is the main treatment, the main antibiotic treatment, or penicillin G. So the main treatment for such anaerobic organism is metronidazole or penicillin G, and the metronidazole is of course preferred, and both given in high doses to penetrate into these devitalized tissues. So just to complete this, by this slide we end this this session, and that's done for the neuro infections. Inshallah, our next session on epilepsy, convulsions, and anticonvulsants. Stay tuned. Wassalamu alaikum wa rahmatullahi wa barakatuh.